Hey everybody, thanks for joining. This is Dr. Matt Fontaine, and today's topic of discussion for the webinar is going to be repetitive motion injuries and understanding how they're caused, what they actually are, how we treat them, and so the end game goal is to get you back to living a life without pain or physical limitations. So I'm going to do my best to simplify things as we go, and we'll deep dive where we need to. So let's jump right in here. Couple of things that we're going to touch on is understanding how repetitive motion injuries occur. Basically, there's a few causes that we see in clinic that limit range of motion and movement. Number one is joint fixation or misalignment of the joints. This occurs in the spine as well as the extremities. Muscle and fascial adhesion. That's primarily going to be the focus of topic today. Muscle spasms and guarding. This is usually due to protective tension and is the result of an acute process injury. So think of things like acute back spasms. They are almost always due to some form of injury to the disc. Next, we have nerve entrapment, and finally, progressive neurologic disorders. So the top four, 1, 2, 3, and 4 here are the most common things that we see in clinic and represent 80 to 90% of the musculoskeletal joint and muscle pain syndromes that we see in clinic. So moving on, I love this quote, as to methods, there may be a million and then some, but principles few. The man who grasps principles can successfully select his own methods. The man who tries methods ignoring principles is sure to have trouble. So one of the things that we see in physical medicine is there are patterns to how the human body moves. And when you understand these principles, we're able to recognize these patterns and apply an integrative approach, which really allows us to touch on several different areas, which is really the key to resolving musculoskeletal injuries. Many times in clinic, one of the things that I see the most common is people, number one, they've not seen anybody and had anybody look at their condition or had a diagnosis, but number two, a lot of times they have gone to see somebody. Maybe they've had x-rays, kind of a limited cursory examination. They may have been told they have arthritis, but all too often providers are failing to look at and evaluate all of the factors that go into creating these injuries. And we spoke about that in just a few slides ago, namely, is there normal joint motion? Is there joint restriction, fixation, or misalignment? Are there adhesions with the fascia that are restricting movement and also causing nerve entrapment? And we're going to get into that today as the main topic of the conversation. So the driving forces behind pain, very simply, oftentimes the joints are not aligned. There can be compression of a joint. There can be torsion or torque, rotation, malposition. There's a lot of different terms you can use. We typically use the term dysfunction, and that just simply implies the joint is not moving correctly. Sometimes that can be the joint's moving too much. It's hypermobile. Usually we'll have to do some stability exercises for that. But when we come to talk about manipulation, the primary mode that we're addressing is a fixated joint. And so, secondly, here is repetitive motion affecting how the muscles, soft tissues, and nerves move, and overworking or improper movements during exercise. And I would include there just activities of daily living. Today, especially amidst COVID-19, people are much more static, working from home, a lot of sitting, which wreaks havoc on our structural system. So one of the most common things that I get asked in clinic is, are my muscles short? Are they weak? Is this weak? Is this tight? And so going back to simple physics, we can look at force equals work times distance. So the muscles need to be able to contract and relax. Think of like a rubber band. A contracted muscle, due to repetitive motion, the muscles will shorten over time, typically due to the demands placed on them. This is very common in the postural muscles. So think of the muscles around the neck and shoulder girdle, the hip flexors, the lower back, the outside muscles of the hip, the calf, the deep muscles in the lower leg. All these muscles have a tendency to shorten and contract over time, thereby rendering them weaker because they're not allowed or able to contract and relax as a normal muscle would. So basic physics kind of dictates a lot of what we're dealing with. So when we do muscle testing in the office, not to get too deep dive here, but one of the things that we'll look at is if a muscle is testing weak, could that be due to the fact that the muscle is actually shortened and therefore just needs to be stretched as opposed to having strengthening exercises thrown at it? Moving on here, this is just a simple slide that talks about some of the factors that go into creating degeneration in the joints over time. Number one is aging, previous joint injury, inflammation, nutritional overload, obesity, metabolic syndrome. And so as we go down, this is a bit of a dip dive into physiology, but it speaks to how several factors can actually affect the cellular function of the articular cartilage in our body, particularly in our joints, as well as the fascia. And over time, that can lead to accelerated wear and tear. So adhesion in scar tissue. What is adhesion? Oftentimes patients will ask me, what do you mean I have adhesion? I haven't had any surgery. Typically, they think that adhesion is the result of previous surgery, and it certainly can be. Adhesion is simply an abnormal region of scar tissue within a soft tissue, usually the muscle, tendon, and or fascia, as well as the nerves that are traveling in and throughout these tissues. What happens is that with trauma, either tears or crush injury, or hypoxia, meaning decreased oxygen to the muscle tissue itself, from sustained or repeated contraction can cause adhesion. And we'll see in a future slide what we mean by this. But in the case of hypoxia, there is really no inflammation. There's just a decreased partial pressure of oxygen. And in the human body, that decreased partial pressure of oxygen actually increases calcium retention, and it stimulates a pathway in the body known as the fibrous adhesion pathway. And that's a bit of a mouthful, but basically that means that causes fibroblasts, cells that your body naturally produce, to be migrated to that area of tightness, and those fibroblasts start to lay down scar tissue, essentially gluing the muscle and the fascia together. Here we are looking at the hypoxic pathway, basically a sustained or repeated contraction. So if you were to take your hand and just create a fist and hold just some general tension there, hold that for about a minute, you'll get a real quick idea of what that feels like to have the muscles start to be in a sustained contraction. Now this goes on all throughout the day with postural muscles, and certainly with muscles in the lower extremity with repetitive motions like running, cycling, etc. Definitely another thing that we see with weightlifting, with combative sports, pretty much any kind of sport and recreation. The time under tension causes, again, tightening of the tissues, the micro blood vessels, which is to say the capillaries, start to become compressed or narrowed. The end result is decreased oxygen to the tissue. And what ends up happening is this drives a couple of chemical pathways in the body. It actually produces free radical production and actually is a chemical trigger for fibroblasts, as we talked about earlier. These pictures here just represent on the bottom left what the fascia looks like in a cadaveric environment. And we can see just some of the red blood cells traveling through the blood vessels and different chemical mediators that move in and about. And on the top left, you can see the intricate anatomy, some superficial muscles here showing the trapezius and some of the splenius and semispinalis muscles underneath. The important thing to note here is that the musculoskeletal system is comprised of several layers of muscle that run in different planes of orientation. They overlap, some muscles sitting on top, some muscles sitting below. There's fascia and nerves intertwined all throughout. And one of the important roles of the fascia is to ensure that those tissue planes are free to move in an unrestricted way. This here is the repetitive motion injury cycle. We start at the very top. We start to have tightness in muscles that can occur due to repetitive motion. Over time, that leads to increased friction, pressure, and tension within that body region, causing decreased circulation, swelling, and edema, and a condition known as hypoxia, which is basically decreased oxygen to the tissue. The end result is increased formulation of scar tissue, or what we call adhesion or fibrosis. So adhesion and scar tissue formation, it is reversible with proper treatment. Fascial treatments like active release, instrument assisted soft tissue release, things like Graston, or what you may be familiar with is some form of scraping with some type of tool. Adhesion is identified through a physical exam, in which case the practitioner actually palpates and feels the area of the tissue and assesses it for slidability. Does the tissue move? Is it glued down and restricted? So real quick, talking about protective guarding, tension, and spasms. Protective guarding, as I said earlier, is a safeguard of the body to prevent full range of motion to protect an injured joint or tissue. Most commonly, we see this in acute back and neck spasms, typically due to an injury of the disc. The nervous system will not allow the muscles to relax so as to prevent loading of the tissues that have decreased load capacity. And then down the bottom, again, back spasms, one of the most common things that we see in terms of protective tension. Nerve entrapment is a really big issue we see with muscle and joint pain syndromes. These repetitive motions oftentimes, I would say more than 80% of the time, result in some form of a nerve entrapment. And the resulting symptoms can be numbness, aching, burning, tension, tingling. Nerve entrapments are responsible for causing these symptoms. And we can see nerves become entrapped between tight glued down muscles at over 156 places in the body. And as I said before, a lot of the symptoms we see in clinic, I would say up to 80% of them have some form of nerve entrapment involved as a critical driver in creating pain and or numbness, tingling. So how do we treat these soft tissue injuries? Well, as I mentioned, one of the most effective is a form of treatment called active release techniques, which is effective for assessing the slidability of the tissue. It also is very effective at identifying areas of peripheral nerve entrapment, whereby the practitioner can place his hands in the tissues and assess for increased tissue tone, decreased sliding of the tissues, understanding of proper anatomy and where the nerves slide allows the practitioner to be able to detect whether there's a nerve entrapment or not. And oftentimes, during the palpation and or stretching of that area, we will recreate symptoms of numbness, tingling, burning, and or pain that also help to confirm the diagnosis. So how did I get injured? Pain is actually a lagging indicator. Pain's built into the nervous system to prevent loading of damaged tissue. However, by the time we have pain, an injury and tissue damage has already occurred. So the main take-home point here is we must respect the process. So if we take acute injury out, slip and falls, car accidents, traumas, most of the things we see are repetitive in nature and occur over time. Oftentimes, they come on gradually. And we always talk in clinic about respecting the process, not the event. Patients will start to experience some form of pain, usually with activity, that will progress to a functional limitation, i.e. the runner who now starts to have pain 1 mile into a run, is difficult to complete a 5K. This can progress down the spectrum to full-on injury progression and eventually leading into impairment. And we're going to talk about some of the things that cause dysfunction in the body. The human structure's ability to handle load, its capacity to handle load, is what creates its ability to function or leads to dysfunction. Changes in how the body moves, decreased range of motion, stiffness in the tissues, all can lead to a less than optimal load distribution. And this dysfunction leads to pathology along a continuum, can start as a mild, can progress to moderate or to severe level of injury. And if the tissue is healthy and becomes loaded in a compensated way, most tissues will eventually not remain healthy over the long haul. So these next several slides are going to show some graphs that are going to help us to identify and to give you a better understanding of something we call symptom threshold. So if we take what's the most that the human body can do, there are several factors that will take away from its ability to handle capacity over time. What we're looking at here is a symptom threshold. So the bar graph on the left shows that it is far below symptom threshold, and that space between the top of the blue graph and the red line represents what we would call a buffer zone, meaning there's capacity there to handle additional load. The bar on the right-hand side has clearly crossed threshold, and there's several factors that cause the human structure to have a lower threshold of injury, and we're going to talk about those over the next few slides. So here's this buffer capacity. Again, in a healthy state, well recovered, well rested, we typically will maintain some form of a buffer capacity whereby we can safely deal with exercise, workouts, activities of daily living. When we look at here, this just represents some of the blocks that contribute to or take away from our ability to handle load. So looking here, joint, soft tissue, muscle imbalance, and then rehab, nutrition, and rest. So the first three being actual anatomical and or functional, and the rehab, nutrition, and rest being things that we can address from a recovery standpoint. Magnitude is another thing to look at. If we look at here, not all blocks are going to be created equal. So we see patients in the office frequently that want to know, do I have a muscle problem? Is it a joint problem? The reality is it's usually muscle, joint, soft tissue, fascia, and the nerve is usually along for the ride. The differences between patient to patient and what makes it individual is that the magnitude of those specific anatomic blocks can change. Somebody who has fairly advanced arthritis in their hip, obviously the joint block would have a greater magnitude, and while they may have some soft tissue adhesion, that may not be the biggest contributor to their lack of functioning. Again, this is just talking again about relationships to load. More load on the tissue or dysfunction lowers the symptom threshold line, and that can fluctuate over time. When we look at treatment, the primary goal is to reduce the dysfunction and raise the symptom threshold, or i.e. to raise the capacity of the human machine. So the goal of treatment is to normalize load and increase capacity across the muscles and joints. Managing symptoms does not fit in here. Useful if it opens a window for other treatment, or if nothing can be done, i.e. if there's an irreducible block. This would be a patient who has moderate to severe arthritis, let's say in a knee, needs to have a knee replacement, but is hoping to put that off for a period of time. Then the goal of treatment would be to try to optimize what we can, with the understanding that a severe arthritic condition in a knee is an irreducible block. So looking at the two main categories of tissues that we deal with, one being the joint and the joint capsule, the other being adhesions in the fascia. Treatment of only one dysfunction is unstable and encourages a recurrence. What we need is a combination of treatment that addresses both the joint dysfunction as well as the fascia and adhesion component. Looking here, these are some of the things that affect either load on the tissue And so these on the left-hand side are activities of daily living, ADLs, our posture, how good, how poor, sport and recreation, how active are we? Are we overtrained? Our capacity is also affected by three major anatomical issues, namely joint, soft tissue, and movement. How well do our joints move? Or is there any degeneration or arthritis, joint fixation? Are there any adhesions? Is there decreased sliding, tendonitis, nerve entrapment, sprains, things of that nature? With regard to movement, we look at whether the human machine is operating at full capacity with regard to how well does it control its ability to move. And then recovery, obviously, has several factors in it: chemical, emotional, sleep, hydration, nutrition. So injuries are cumulative over time. And we use this graph in clinic almost on a daily basis to educate patients on what's going on with their body at that particular instance in time. And so these three blocks are the primary three things that are going to affect your ability to function. Anatomical defects are things like rotator cuff tears or meniscal tears in the knee, sprain strains, any kind of arthritic condition. The next block, fuel, sleep, stress, and recovery, is somewhat manageable and under our control. How much sleep are we getting? Are we recovered? Are we overstressed? And then lastly, the functional diagnosis block. This is where muscle imbalance comes in, poor movement in a joint, soft tissue adhesion. So we can address all three of those. The anatomical defects can actually be improved upon with manual therapy. Functional diagnosis obviously can be improved upon with joint manipulation, fascial manipulation, corrective rehab exercises, and other modalities. And fuel, sleep, stress, and recovery is a lifestyle management issue, which can also be affected. And so on top of these three blocks, we typically see patients adding on other things such as their activities of daily living and their workouts, which we describe as workout of the day. So if these three blocks are managed well, i.e. I don't have an anatomic deficit and I am properly fueling and hydrating and sleeping, and I am managing stress well, and I don't have a significant functional diagnosis, well, you can see that that will actually increase some capacity to their injury threshold level. This is a load recovery curve, and again, it just basically shows us starting at point A, if I were to go through, let's say, a really hard workout, ideally, even though during a workout the body's going to incur some tissue damage, it should recover and even super compensate prior to its next workout. That's the main goal with exercise, is to provide enough stress to cause the body to start to repair damage, grow back stronger, and to super compensate. Over time, though, we can see accumulation of workouts in weeks and months. If not adequately recovered, we can start to have decreased capacity and overtraining. Some of the factors that affect our recovery are obviously genetics. 2, nutrition. 3 is stress. Again, rest. How much active rest are we getting? And that basically speaks to unloading. So over the course of a training week, are we taking 1 or 2 days to recover before the next hard week of work? And then again, sleep, obviously, super important. These two curves here just show growth. So I work out and I recover and I super compensate. I work out again and I keep progressing upward, as opposed to the curve on the bottom, which overtraining just leads to us digging a bigger and bigger hole. Usually due to intense training with inadequate recovery. So the body really needs to have a balance between energy expenditure and recovery. And if we look here on this graph, set load over time, why did I get hurt on my last repetition? Well, the answer for most of us is we didn't. This was starting to reduce our injury threshold and reduce our capacity over time until we exceed the capacity of the tissues and we sustain an injury, sprain, strain, or even more significant injury. So our first priority of treatment is to reduce the dysfunction. This starts with manipulation of the joints and fascia. That will lead to an improved capacity of the human body. And this treatment continues until the dysfunction is eliminated, the dysfunction is rendered stable, and or is considered to be irreducible. And again, these are patients that would require other intervention, patients who have arthritis that's advanced and severe that may benefit from regenerative medicine or total joint replacement. So the primary objectives in treating these repetitive motion injuries is to reduce, resolve pain, and improve and optimize for function. So again, respecting the process, most patients are going to start out with some sort of pain that comes on rather gradual and can progress over time to a noticeable functional limitation. And then following the spectrum through this progresses to injury progression and ultimately impairment. And it's a big distinction to make between a functional limitation and an impairment. Functional limitations can be treated usually over the course of 4 to 8 weeks of acute care, and then we start to phase into more active performance care, as opposed to impairment, which usually carries with it some form of an irreducible block and permanent impairment. So the difference, how do we tie all this together with repetitive motion injuries? We need to have an integrative treatment. Not just an exercise video, not just therapies, but an all-inclusive multimodal approach, starting with soft tissue and fascia work, structural work on the joints, so things like active release, Graston, and of course joint manipulation are the most important things we do in clinic in terms of physical medicine, and then rounding that out with functional rehabilitative exercises to help us to improve our motor control, restore normal motion, and get us back into the game. So that concludes the webinar on repetitive motion injuries. Be sure to check out some of our links. We have some great videos on discussing active release at a little more deep dive of what it is, as well as pretty extensive rehab video content broken down by playlist, and you can get a better sense of some of the things we do from an active rehab standpoint to rehabilitate motion with these injuries. But the bottom line is these injuries are undiagnosed. They go largely undiagnosed. 1 in 3 visits to a musculoskeletal, 1 in 3 1 in 3 visits to a primary care physician are for musculoskeletal injuries or complaints. And these soft tissue and joint injuries go largely undiagnosed, mostly due to a lack of understanding of how integrative the human machine actually is. And so getting these injuries resolved starts with getting an accurate diagnosis. And that starts with a physical exam, a proper medical history, and being able to address and assess movement of the joints, movement of the soft tissues, manual muscle testing, and looking at overall movement patterns to assess for the dysfunction and ultimately to restore optimal movement to the human machine. Thank you so much for your attention. Our goal is to try to keep this under 30 minutes, and I think we're coming in right at time. So again, really appreciate everybody being here, and continue to stay tuned as we roll out more webinars onto our website in the near future on interesting topics as we're getting inquiries from our patients across the board.